Okay, so as we were discussing, the elbow is a super weird, complicated joint, and there's a lot of things going on there. So let's cover that a little bit and see what's going on. So one of the cool things about, as we talked about, is that carrying angle. And I'm going to look and see, do you have symmetry? Do you have any swelling? Do you have any things that look atypical? Well, I can tell you one that's super easy to see. If you rupture your distal biceps, as many people who are doing CrossFit, being pushed by people that are half their age in the gym and being pushed too much, they rupture the distal biceps here, and then your biceps contour shifts up. So if we come right here and we look, you have a nice distal muscle belly that's way down, which is what you want. That level, you're about 2 finger breaths, will go up 4 finger breaths, and it's disconnected. And what's weird about that is it's not, so if I test you in supination like that, whether you have a good biceps or not, you're going to be super strong, and it's not going to hurt, because that's mostly brachialis, that underlying broad, strong muscle that gives us our basic curling capability. The biceps is cool because, and we can watch your biceps because it's well defined, is we go from pronation to supination with a little resistance. I'll just resist a little bit. You go there, you can see it ball up a little bit. So it's contracting and pulling up. That biceps is the primary supinator. So I'm testing that. Now, if I have you supinate and it hurts or it's weak, then we know something's going on right there. Secondarily, if I have you do a pronated curl in that position, that will hurt like crazy if you have even a partial tear of the distal biceps. And that pain, people say, well, it's not my biceps, it's down in here, but that's where it attaches. It's way down in here. It attaches to the radius and rotates the radius. So that's a super cool, super great, easy way to test. Now, if we look at the lateral epicondyle, we talked about tennis elbow, lateral epicondylitis, that's down here, very pinpoint. You know, people say, how did you know where it was? Well, it's not hard, because that's where everything happens, and it's right there. The ECRB tendon lies deep right next to the bone, and it will often be swollen, spongy, very tender. So we palpate that, we can see it, we sponge it, and sometimes I can feel, if it's a medium-sized, partial thickness tear, I can feel the defect in there just with my thumb, and people don't like that. You don't keep torturing them. Then, with the elbow straight, I have you pull up against me, and like that, and that will hurt badly. Now, for some reason, when we flex this way and pull up again, it hurts a little less. I don't even know why that is. I've never been able to figure that out. But both of those will hurt with tennis elbow. And that's a pretty simple, straightforward diagnosis. Now, on the inside, I'll use this elbow. The medial epicondyle, which is golfer's elbow, it tends to be even more tender. And I think that's because the ulnar nerve lies so close to it. And it's very spongy, very swollen, very tender right there. It's a little bit different anatomically in terms of the way the tendon inserts, so these need surgery much less, but man, when they're on fire, they really hurt. People can't even press, it's this movement here, that's what really causes that to hurt there. Now, in your case, and we're going to talk about the nerves, I think, later, but I want to feel your nerve, and you can see that I can roll your ulnar nerve, the funny bone nerve, up over that medial epicondyle bone. So you have a very mobile ulnar nerve. And we'll talk about that a little more, but that's a normal variant, and that's just what it is, and that's fine. Okay, let's see. Now, very importantly in the elbow, we want to look at range of motion. It's very common for athletes, longtime weightlifters, football players, all sorts of people to have a contracture of the elbow. So you have nice, full, mild hyperextension, not dramatic. If you have genetic laxity, sometimes that'll go back 45 degrees. You don't, it's just nice, full, easy motion, I would call it minus 10 degrees at the most. And then I look at your flexion, which is normally up around 150 degrees and so forth. Again, from that zero position. Very important to look at that. We know a functional arc is about a 100-degree arc. We can function well, but we have to get up to about 130 to be able to get to our hair and face and mouth. And so that's a common result of minor fractures in the elbow, inflammation in the elbow, and so forth. Professional pitchers, almost all of them have about a 15 to 20 degree elbow contracture from all the loads that have been put on the elbow, and they're functional, they're fine. we're going to talk about the nerves later. So that's really the triceps. So the triceps attaches here on the olecranon, and you've got a big, well-developed triceps here, and we've got your triceps inserting there. Now we can watch that, and people who are doing a lot of weightlifting, especially if they've been out of it for a long time, or they're doing a lot of push-ups, things, that's where they'll get the triceps tendonitis or a partial rupture. You talked about the eccentric loading. If you land hard and you have that eccentric load, you can tear off part or all of the triceps. That's a miserable, always surgical diagnosis because you just can't do anything. You can't even push up out of a chair. You need that big triceps. So we look at that. Now, if you just have tendonitis, what I'll do is I'll hyperflex and then have you push against me like this, push hard. That hurts like crazy if you have any inflammation there, because there's such a biomechanical disadvantage when it's trying to extend from a very flexed position. You know better than me, and so what do you think is the ideal, since you do a lot of this and talk to a lot of your patients about it, what do you think is I don't know the answer to this, the ideal position for doing triceps workouts?
I mean, I think the literature actually suggests that you want to be in an extended position of the humerus, right? Or flexed positions, right? So you want a humeral flexed, so that
to stretch the
triceps. You want the tricep to be under a stretch.
Interesting. So it's better than doing them down here.
Correct.
Interesting.
So basically, if you're on your back doing like a skull crusher, or if you're using a pulley, doing it kind of overhead.
Okay, that's informative.
But that, of course, assumes your shoulders can tolerate it. So, for example, when I was recovering from my surgery, the only thing I could do
down here,
I'm having a towel between my arms, and I'm doing this way, and I'm doing this way, and that's all I could do. Right. So it's really just a function of
okay, that's great. I did not know that, and I hadn't even really thought about that before. That's good to know. Okay, so that's pretty much all of the muscle tendon units that are commonly injured around the elbow.